It's the camera. Hello, everybody. How are you guys today? My name is Ash Bowen. I'm a urologist with the University of Oklahoma, and with the COVID, we thought a webinar might be a good idea to reach men and talk about something they don't get to maybe talk about with a regular doctor or their cardiologist, and that would be erectile dysfunction. Let's see. It is noon now, so I think we are okay to begin. If you have any questions, there's a chat there at the bottom. Be sure to type it. I'm going to put my office phone number down here right now, as well as my website, which has a online appointment request. If anything pops up that you want to talk in person about, okay, or I'd be happy to do we're doing telemed visits as well during COVID. All right, well, let's get started here. So housekeeping, your mics have been turned off. If you have questions, type it in the Q&A. If you want to ask a question verbally, I'll be happy to turn, Walter or I will be happy to turn the mic on and ask verbally as well, okay? So as I said, I'm an associate professor at the University of Oklahoma. I specialize in men's health and penile implants. I've been here in Edmond, Oklahoma since 2012, and we do well over 30 to 40 penile implants a year. I also do minimally invasive surgery, taking care of kidney stones and cancer. So our goal today is to educate men and their partners about ED treatment options and answer any questions that you guys may have. So we've done the introduction. We'll talk about what is erectile dysfunction, what causes ED, and what does ED mean for your health. And then we'll go over all the treatment options from pills to procedures, and talk about the pros and cons of each one. Give you some tips on how to get the most out of these treatments, and we'll have a brief video from a patient educator. My patient educator, Bob, was not able to join us today, but we'll put Bob's information in the chat for you guys if you want to contact somebody and find out what his experience was with erectile dysfunction at our institution. And then, like I said, time for question and answers. So erectile dysfunction, ED, is the consistent inability to sustain an erection sufficient for sexual intercourse. ED can be total inability to achieve an erection, or the inability to get an erection that's firm enough to penetrate, or, and usually the first sign of erectile dysfunction is men aren't able to sustain their erection prior to orgasm. So just when you get started, the air goes out of the tire, and that's usually the first sign. And then the next is rigid enough to penetrate, and then total inability to get an erection. Facts about erectile dysfunction. If you have ED, you are certainly not alone. 30 million American men suffer from erectile dysfunction, and depending on your age is the biggest factor in how common it is. So one thing we like to tell people is if you're over the age of 40, about 40% of men your age have some amount of erectile dysfunction. If you're in your 70s, up to 70% of men can have erectile dysfunction. Most men with ED still have the ability to have orgasm and father children, but often have difficulty doing that because of their inability to sustain that erection. ED is not a normal part of aging, and it's not inevitable, and it's certainly very treatable. In most cases, ED can be overcome and even cured. So research has shown that ED, that greater than 80% of men suffering from ED, it can be traced to an actual physical disorder. From the common causes: injury, brain, spinal cord, disease such as diabetes or heart disease, surgery such as colon surgery, prostate surgery being the most common, and some substance abuse, tobacco, drugs, alcohol, or medications such as blood pressure medications can all be a physical cause of ED. A lot of guys, we see for the first time, they think that, erectile dysfunction is a big problem in their mind. And that is the rare exception. I probably see a person that has ED related to, depression, anxiety, mental factors of ED is less than 5% of men we see with erectile dysfunction. So it's almost always traceable to some physical cause. And so don't think it's something in your head, because it rarely is. An important thing for erectile dysfunction is the penis is a vascular organ. And one thing is the penis may actually be the check engine light for your heart. So loss of rigidity is the earliest sign of endothelial dysfunction. And the last sign of endothelial dysfunction is a heart attack. So early erectile dysfunction may be an early sign of coronary artery disease. In fact, we know that one out of 8 men who have erectile dysfunction will have a heart attack over the next 8 years. So this may be an early opportunity for you to think about seeing a cardiologist, especially if you have risk factors: smoking, family history, diabetes, high blood pressure, in addition to your erectile dysfunction. And certainly if you get to the point of erectile dysfunction and meds aren't working, we generally recommend all patients with ED see a cardiologist at that point. Other risk factors for ED: aging, as we said. The aging in of itself is not the cause, but cumulative damage from other issues such as high blood pressure, diabetes, blood pressure medications all accumulate with age. Depression can be a cause of erectile dysfunction. Certainly cardiac disease, known risk factor for ED. Certain medications, thiazides and beta blockers thiazides are HCTZ, commonly prescribed for high blood pressure. Beta blockers are the most commonly prescribed high blood pressure medications. And even ones that aren't on this list, like lisinopril and calcium channel blockers, even though they cause less ED than these two, they can still cause erectile dysfunction. We see that pretty commonly. Guys come into the office, they started blood pressure medicine three months ago, and the erections aren't as good as they used to be. Certainly lifestyle things can contribute to erectile dysfunction: stress, either outside the home or inside the home, alcohol abuse. Ben Franklin was famously quoted as saying it increases the desire and takes away the performance. And smoking is a known risk factor for ED. In fact, it's one that's not modifiable. So if you stop smoking, it's really unlikely. The damage is usually done. Not that anybody shouldn't stop smoking, but if you have erectile dysfunction caused by smoking, it's usually not reversible. With just quitting smoking now, it can be treated well with medications and other therapies. The process of aging increases your risk of erectile dysfunction. Your testosterone goes down with age. Your physical performance, penile size can all go down with age. Memory and psychological issues also happen with age. And then relationship and partner issues. Vaginal dryness is extremely common after menopause, and obviously that can be treated well, but can be treated as well, but a lot of women won't ask for it, especially if that kind of treatment, especially if their partner is struggling with issues of his own. So not uncommonly, we'll get somebody fixed up on their erectile dysfunction, and then their wife's or partner's ability to participate with intimacy is down because of her vaginal issues. So it's best to get those treated both at the same time, so you're both ready to go at the same time if they're there. The most common reasons why patients go to the doctor between the age of 45 and 64, 3 of those 4 reasons listed on the screen are all risk factors for erectile dysfunction. So it's not uncommon for, if you have one of these issues, to also have trouble with ED. Diabetes and hypertension are 2 of the most common risk factors for ED, even more common than cardiac disease. Factors impacting ED in patients with diabetes usually increase age, the duration of diabetes. So the longer you're a diabetic, the more likely you are to have trouble with erections. Poor glycemic control. So if your A1C is 7, 8, 9, 10, the higher it is, the more likely you are to develop diabetes. And then if you have complications of diabetes, such as problems with nerves or problems with blood flow to the legs, those can make you at higher risk for ED, because they're all markers of not good control for diabetes. Hypertension, 68% of men with high blood pressure also report ED. 45% of men, and this is age 34 to 75 years of age, have severe ED with high blood pressure. So certainly it's much more prevalent in that disease because of, it causes it. Other risk factors for ED, so diabetes, men with diabetes are 4 times the risk of the average population. Prostate disease, 3 times the risk. Vascular disease, 2.5. Cardiac disease, 2 times. High blood pressure, 1.5 times. And the longer you have high blood pressure, the higher this number will go. Prostate cancer, that's a common issue associated with ED. The cancer itself does not cause erectile dysfunction, but many of the treatment options do, including surgery and radiation. At least 30% of men after radical prostatectomy surgery will have poor erections and need some help in this area. And radiation, the erectile dysfunction isn't as common up front, but it does get more common with time. And we know at 2 years after treatment, whether you had surgery or radiation, about 50% of men will have trouble with erections. Smoking increases the risk of moderate to complete ED 2 times, or you're twice as likely to get erectile dysfunction if you have a history of smoking. But the smoking is less common in former smokers than it is to current smokers. So if you catch it in time before the damage occurs, you can reduce your risk of having ED later on in age. And certainly medications, we talked about these 2 high blood pressure medications, thiazides, HCTZ, and beta blockers. Beta blockers are any medication that ends in OLOL. So metoprolol, labetalol, propranolol, all can cause erectile dysfunction. So how does an erection occur? An erection is an involuntary reaction in response to sexual stimulation and excitement. So sexual stimulation causes the brain, then the nerves, the heart, blood vessels, all to increase nerve signaling and blood flow into the penis. And as the the nerves come down here past the prostate and tell the artery to relax and the veins to contract and the blood to fill up with the penis to fill up with blood. So as the arteries dilate, the penile chambers fill with blood, and the penis becomes erect and stiff. These two chambers right here on the right are the part of the penis that fills with blood. This is the urethra at the bottom. This is where the urine passes through. As the chambers fill, expand, the penis becomes firm and elongated, and the result is an erection. And then after completion of orgasm, ejaculation, a nerve signal sends that signal to the artery to constrict. The blood flow to the penis decreases, and the penis detumesces or deflates. So that's our background on what common causes of erectile dysfunction, the epidemiology, or how common it is, and now we're going to go into some treatment options. So everybody knows about the oral drug therapies. Viagra and Cialis are by far the most common. Levitra and Avanafil is also available now, FDA approved. Avanafil is not on this list, but they're much more. Levitra and Avanafil are much more expensive than the generic sildenafil and tadalafil. These pills help men achieve erections in response to sexual stimulation. So if you have nerve damage, these medications really aren't that effective. They can work, but really it needs a healthy nerve response to make the pills work. 30% of men who try it, they will find it won't work. You do have to take it an hour before sexual activity. Another barrier that a lot of guys had with these pills was the cost. Actually, that's been fixed these days. The cost, you can get 5 tablets of 100 milligram Viagra or Cialis generic now for around $10. So less, around $2 a pill per dose, which is way better than the $30 a dose days that we were seeing, not even 3 years ago. So GoodRx is a great solution. GoodRx.com for getting coupons for cheap Cialis and cheap generic Viagra at your local pharmacy, and you don't have to go to Canada or Mexico to get these at an affordable price now. The difference between the two, I will tell you, Viagra works better on an empty stomach. So if you go out to dinner, have a glass of wine, and then try and take your Viagra right after that, so you're ready by the time you get home. Back in the days when we were doing dinner out, Viagra wasn't always the best choice. Cialis is not affected by food intake, so you can take Cialis right after a meal, no problem. But Viagra can lose its potency by up to 50% if you've just eaten a big meal. Side effects, any medication has side effects. The most common one associated with both of these medication is headaches, and facial flushing is next. Upset stomach is pretty rare. Temporary visual effects, that's the blue halos you usually see with Viagra or sildenafil. They're harmless, but they can be alarming the first time you see it. And then back pain and muscle aches is more associated with Cialis than Viagra. The next option is penile injection therapy. Any of you guys who listen to sports radio know this is the solution that you hear about the men's clinic advertisements. Guaranteed solution for $99 office visit. They're offering penile injection therapies. It's usually overpriced in those scenarios. We can get it much cheaper, a 3-month supply for $90, $120 at a compounding pharmacy. versus men's clinic prices usually run $2 to $3 grand for 1 year. They do it as a subscription model, and they usually require 6 months to a year commitment on subscription, which is ironic because we know that men who start injection therapy, only 25% will still be taking them at 1 year. So be wary of some of those business practices. The advantage with the injection is it's quick onset. So after you give yourself an injection, you'll have an erection usually within 5 to 10 minutes, sometimes 20, especially when you're starting out, figuring out the dose that's right for you. The disadvantages of the shot, the erection lasting longer than 4 hours, which everybody hears about on the Viagra, heard about on the Viagra and the Cialis commercial. That is rarely happens with the pills, but can happen with the shots, especially if you don't start at a low dose and slowly work your way up. Possible bleeding at the injection site is pretty rare unless you're on blood thinners all the time. Then you may need to hold pressure. Pain at the injection site is probably the #1 complaint with men on this therapy. It does require training, but we can usually do that teaching in the office in about an hour, and can cause bruising and prolonged erection. Kind of one of the most feared complication of penile injection therapy is Peyronie's disease, and this can be happen in about 5% of men who start injections, and it can cause shortening and curvature of the penis, which is something that nobody wants, but is a known risk. Again, long-term tolerability, less than 1 in 4 men who are prescribed this therapy are still using it a year, and then some men have a fear of sticking needles into such a sensitive area. Vacuum erection devices. This therapy has been around for well over 50 years. They used to be really well covered by insurance, but after Medicare stopped paying for them, most other insurance have stopped covering them as well. They do allow on-demand use, so you take it around in a little Dob kit, and when you're ready to use it, it works. It's non-invasive. It's not medication. It's a one-time cost, so you buy the device, and it's going to last 5 or 6 years. You may have to replace the rings every once in a while, so it's cost-effective. Cost-wise, it's pretty cheap. You can now get a vacuum in the $150 to the $250 range and get a pretty good quality one. You can get low-quality ones for under $50. It may have therapeutic benefits, especially after like prostate surgery, with stretching out the penis and putting blood flow back in the penis. There are training. All the companies that sell them usually have 24-hour training available online. Disadvantage is erections aren't warm to the touch. Ejaculation may be absent, and there's a learning curve to some of this. So may have to shave, or which size band to use, and things like that. So vacuum devices are good. They're pretty effective. They work 70-80% of the time. Similar story on tolerability. In fact, again, about 1 in 4 men who start the vacuum therapy are still using it at a year due to the pain with the ring or ineffectiveness. But I think the vacuum is good for older patients who are more birthday and anniversary. Once a month, once every other month, they have intimacy. It's not a major part of their life, and they just want something to get by. I think the vacuum has a role there, but if you want to get back to the you from 20 years ago, where you're having intimacy a couple times a week, I think you'll be unsatisfied with the vacuum long term. Insertable drugs are almost completely out of the market. They are available. Their cost is exponential. I think the cost per dose on this is now north of $150. So very, very few patients can afford it. It's the same medication that's in the injections, but it's a little suppository that goes in the tip of the penis or the urethra, and then it absorbs and into the blood flow of the urethra. It doesn't work as good as the shots. You still have penile pain associated with it, but if you got lots of money and are afraid of needles, this is your solution. But for most people, I haven't written urethral suppositories in 8 or 10 years. Next, we get into procedural options, and this really gets into curing erectile dysfunction. The pills, the injections, the vacuum, that's a treatment. You take a pill before you want to have sex, you give yourself a shot. The penile prosthesis, either malleable or inflatable, cures the problem and it becomes part of you. So when you go on vacation, it goes with you. You don't have to take a cooler to ice down the injections, or make sure you have a refill on the pills. Where you go, it goes, and when you're ready, it's ready. So the malleable penile prosthesis is a bendable rod that goes on the inside of the penis. We custom fit it to your penile size, and it's totally concealed within the body. It's easy to activate and deactivate, so people with limited hand use, a malleable might be an easier option just because you bend it up and down, and it's ease of use. If you wear tighter fitting or fitting clothes, you may be concerned about the device not being totally hidden. If you go to the golf club or the gym and are concerned about having penile fullness all the time, you may want to look at the inflatable, which we'll talk about next. And it's also the least expensive, but as we'll talk about in a minute, insurance will cover both of these procedures in most cases. The inflatable penile prosthesis, this is the Cadillac of erectile dysfunction solutions. It is inflatable, so it sort of mimics when you want an erection, you get an erection. When you want to have a flaccid penis, you have a flaccid penis. They're easy to use. One-step deflation. You hit the button, you squeeze the penis, and it's totally concealed in the body. Nobody knows you have it. There's a small incision in the scrotum to put it in, and that's usually disappeared by 6 months. Acts and feels like a natural erection, and it'll expand the length and girth of the penis over time. So that versus the malleable, which is kind of static. The inflatable penile implant over time will stretch out and grow with the penis. In fact, most people, after they've had the penile implant in for a year, have a bigger penis afterwards than they had before going in. There are 3 components to the penile implant. The reservoir is the fluid collection you see up at the top. The cylinders are the part that go inside the penis, and then the control pump is right here inside the scrotum. And the control pump is what you use to inflate and deflate. The rest of this is completely concealed inside the body, and nobody knows you have it in but you. So here is a animation of how to inflate and deflate the video, or inflate and deflate the implant. So the fluid reservoir, cylinders inside the shaft of the penis, and we custom fit those to your penis. And then there is the control pump inside the scrotum. And you can see, squeeze the device, the penile cylinders will fill with salt water, and usually takes about 6 to 8 squeezes, depending on how large the penis is, to completely inflate. And then to deflate, you hit the release button, squeeze the penis, and you go back down to flaccid um, state. So, this video was a minute and 12 seconds. So you can be ready to go with a stiff erection whenever you want, within about 10 to 30 seconds of you and your wife ready to be romantic. All right. The penile implant is a procedure, and any procedure has risks. The most, thing we fear the most is probably one of the least common, and that's infection. The risk of infection with a new penile implant in a healthy man is about 1 to 3%, and that's going down. The Titan device is antibiotic impregnable, and that means while we're doing the surgery, we soak it in antibiotics that absorb into the implant and are emanated from the implant for a couple of weeks to reduce the risk of infection. And we give you strong antibiotics at the time of the procedure. We wash you for 10 minutes. We give you a special soap to use the night before. We wash our hands for 10 minutes, and we change our gloves 3 times throughout the procedure. So all those to minimize the risk of infections. Once you go the penile implant route, you're going to be cured of ED. But also, if you take the implant out, the erections aren't going back to the way they were, 2 years ago. Once you have an implant in, you have to stay with an implant from here on out. But if it does have a mechanical problem, which is 5 to 10% over a 15-year period, it can be swapped out for a brand new one with an outpatient procedure. Erosion or wearing away the tissue next to the implant is fairly rare. Unwanted movement of the device within the body is also pretty rare, and chronic pain is under 1%. Insurance coverage: most insurance plans cover the penile implant. Medicare covers 80% of the penile implant. If you have a secondary, which Medicare covers 80% of everything, if you have a secondary, your copay may be very low. If you want to check with your insurance company and see exactly what your out-of-pocket will be, you can call them, the number on the back of your insurance card, and give them the surgery code, and I will give you the information that you need to tell them, and outpatient in a facility. That means outpatient in a hospital. And if you call your insurance and give them that surgery code, they can tell you exactly what your out-of-pocket will be at home. It is a reimbursement, and Coloplast's office or my office can help you if you have issues. But your insurance company can tell you exactly what your out-of-pocket will be. And there are alternative financing options if you don't have insurance. So learn more. If coloplastmenshealth.com is an excellent resource for erectile dysfunction. If Spanish is your preferred language, lababita.com is a excellent resource. There's information there on Peyronie's, male urinary incontinence, testicular implants, links to surgeons' websites, including my own, or you can schedule an online appointment to talk to a patient educator if you have trouble reaching Bob here locally. So next we're going to, since Bob wasn't available today, we have a quick video of Stan and Teresa, who have gone through the penile implant journey, and they're going to share their experience.
Hi, my name is Stan Rydelic, and I'm 61 years old, and I live in South Carolina.
I'm Teresa Rydelic. I'm 60 years old, and I met this gentleman when I was 15 years old, and we've been together ever since.
I've been married to my wife, Teresa, we've been debating this, 39 years. 39 years. 39 years.
October.
39 years of bliss. About three and a half years ago, I ended up getting ill. I thought I had the flu. It turned out that I had complete liver failure, and so unfortunately, or fortunately, I had to have a liver transplant. As part of the procedure to nourish my liver, I found out what they did is they rerouted some of my blood flow, and so I ended up with a condition called arterial insufficiency, which basically means that the lower part of my body had insufficient blood flow. After I had my liver transplant and I was feeling well again, and then I found out that things were not happening romantically. It was kind of a surprise. So what I did was I asked my general practitioner, and so he immediately says, well, you know what? All you need is some Viagra. So what he did was he gave me a prescription for Viagra. I went home. I remember that evening, I was thinking, oh, how wonderful, Viagra. Of course, it's going to be a great evening. So what I did is I put some music on, poured some wine for my wife, lit some candles, and guess what? Nothing happened. So I went back, and and every time we're going in, it's just like it's 2 weeks or so between appointments, and it's still like nothing's happening, and you start to really get very discouraged. So the doctor gave me a choice. He says we could use vacuum erection devices, he says, or we can also use an injection. So I said, well, let's try the vacuum thing first. That was horrifying. Well, first of all, in my opinion, it was horrifying. It didn't really work. So that was like a one-time shot. And then we tried it was Trimix that I tried. And so I thought that was going to be great. Went home, and again, since there was a tiny bit of success, I thought this was going to be a great evening. So you try to get all romantic, and then you say, oh, excuse me, honey, I have to go into the bathroom and inject my penis with Trimix. I did everything that I could, and quite honestly, I had never even heard of a penile implant. And so when this doctor I went to, he was a young gun, kind of like, cutting edge, and he says, I think the only thing that we could do, he says, to really guarantee that you can get an erection is a penile implant. So Teresa was a part of the process. She came to the doctor's office with me, and what we did is we had the discussion about it in penile implant, and she said, look, if it means that much to you, she goes, I want you back how you were. I want you happy. A couple things came up. The first one that I worried about was the procedure, a painful procedure. And quite honestly, I was told, and after experiencing it, it's an outpatient procedure. It takes less than an hour, in many cases a half an hour or less. Another thing that concerned me also, and this one's going to sound really, really very strange, but I really worried that I would have the desire to have sex.
Well, it's kind of ironic because that's exactly how I felt. I felt like, well, he's going to get this implant. We hadn't had sex in so long. Maybe that chapter's over. And I think that a lot of women worry that they're not going to be ready for this new adventure like they were. And it actually has been a renewal of our relationship in one area. And so I'm glad. I'm just glad it's freeing. It's taken on where we can be spontaneous, just so different than years before.
There was a romance.
Yeah.
There was a spark that was put back that we didn't know went out. The thing that's really, I think, been wonderful with an implant, with the implant, which I honestly, I don't consider I have an implant anymore. It's just, it's a part of me.
Right.
There's no, well, first of all, from the standpoint, if you look at me, if you saw me in the shower or whatever, you cannot tell that I've had an implant at all. And then also from the other standpoint is you have complete spontaneity. There is never anything where you have to say, okay, you know what, I'm going to take a pill and wait a half an hour for it to happen. If you're in the mood, you're in the mood.
Right.
And you know, I mean, it turns back the clock. I mean, I honestly feel like we're in our 20s or 30s.
Since the implant, there's a confidence there that is actually very sexy. And that confidence is something that I think the implant did for us. And I don't worry that it was me, you know, that maybe I wasn't something that he was needing. No, we're perfect for one another, and now we have back our love life. If I could give some advice to someone dealing with this, a couple dealing with this, I would say talk to one another, be honest and open and loving, because the answer may be no. The answer may be, no, I don't want to do this, and it may be, I've been thinking about this. So I think communication is the key.
If I could give a piece of advice to anyone suffering from erectile dysfunction, it is the fact that you have one life and you have the choice to choose how you live your life and at what level of quality you live your life. So if you're suffering with something like erectile dysfunction, that's fine, you can live with it, but you don't have to. It's something that is so easily fixed, and you could have the quality back in your life that makes you a whole person again.
Put a note in the chat here. If you've had trouble with coming in and out, technical issues or anything like that, a full recording of this talk will be sent to your email address that you registered with. Okay. And now we'll take any questions and answers. I think Stan and Teresa did a really good job of explaining how much the lack of a intimate relationship had on their emotional relationship. I think that's really a underreported benefit of restoring erectile function is, you're not shy about initiating intimacy, holding hands, giving a hug or a kiss. A lot of guys, when they don't have confidence in what's going to happen next with their erectile, is the shot going to work? Is the pill going to work? They don't have that confidence. They are shy about initiating, and then there's a cycle of self guilt. The wife thinks it's her, and the husband is embarrassed, and the pills and the shots treat that problem, but the implant cures that problem. So I would want you to consider that. Another common question, especially for men after prostate cancer, men don't feel like they're necessarily entitled to be back to their normal self after cancer surgery. Versus, women, if they have a bad breast cancer and need breast surgery to, such as a mastectomy, it is, common and expected to get fully reconstructed. They have, it's a part of the process. After the cancer's removed, the flap is made, the nipple is tattooed in ink, and the breast implant is put in that order, and they move on about their normal life. And a lot of men we see with prostate cancer, they necessarily don't feel entitled. They think that's the price that they had to pay to beat their cancer. And I hope I'm really hoping to change attitudes with that. And first question is, with this implant, does a person still have orgasm? Absolutely. Orgasm is not changed at all with the implant. The nerves that control orgasm run over the top of the penis. When we insert the implant with a small incision in the scrotum, we're working on the bottom of the penis. So it has really no impact on orgasm. Now, certain other things can have effect on orgasm that are not implant or erectile dysfunction related. Low testosterone, prostate surgery, or enlarged prostate medications can all impact orgasm and ejaculation. But the implant has no effect on it. So it should be the same, the day after surgery as it was the day before. Other questions? Well, I know it's been 45 minutes. I'd like to thank you, gentlemen and ladies, for your time. I hope you learned something. If you have any questions, please don't feel free to reach out to me or Bob. You can see Bob's number. I'll put it, I don't know if the chat will show up on the recording, but Bob's phone number is 405-818-7971. And a lot of people think it's an imposition to call Bob, but he is very happy to help. He is compensated for his time to help, so don't feel it's an imposition. You can also email Bob if you want. He can give you his email, or if you call my office, I can give you his email over the phone. But Bob's number, 405-818-7971, and he can detail his experience and how it's improved him and Vicky's relationship and love life. And if you want to talk to us, give my office a call, 405-340-1279, or reach out to us via the website, urologyoklahoma.com, to schedule an appointment. Thank you guys so much. Y'all have a good day and have a happy Memorial Day. And stay safe out there, okay?